What are risks that maybe the clinician out there who's listening may not appreciate if they fly into a primarily direct access and primary care role without, giving some considerable thought to or some preparation for?
Sure. I guess my first thought would be slow down. Really, really, really take your time in your history to make sure you're not dealing with a red flag or a yellow flag. And if you are, do you know what to do quickly, right? And explain to the patient. I think that would be, safety, safety, safety. I think those are the big things. And then be willing. I'm going to quote Mark Miller. One of his favorite saying is, "Don't fall in love with your hypothesis. You need to change it." Right? We call it practicing medicine, right? So if you have, let's say you determined that, hey, this patient's safe to move, no yellow, red flags. You've got a diagnosis or a classification, and you're going down this pathway, and then something doesn't seem right. You need to be willing to back out of that. Don't fall in love with your theory and say, okay, I need to retool this. I'll give you a quick example. When I was a civilian physical therapist, I had a let's say geriatric patient, but fit, and it looks like I was able to evaluate his low back and classify him. I'll just use the word derangement. He showed an erectional preference, sent him away. Everybody's happy. Everybody's doing good. He comes back, and now he's obstructed to that motion. And I'm like, well, this is strange. So I reevaluate him. And I can't remember if he showed a directional preference reflection or a lateral movement. I'm like, okay, that's a little strange. I kept it in the back of my head, sent him on his way. He came back for the third visit, and he was obstructed to that motion. I go, you know what? This is absolutely not right. Obviously this is before I was in the primary care setting. Send him away. His wife comes back to visit me personally, I think 2 or 3 days later, and go, hey, listen, because I sent him back to his primary care physician. He's got worked up. He's got spinal mets, cancer in his spine. So I think that's an example of, like, at first, this looks straightforward. I'm happy. We're high fives, but by the third visit, I'm not telling this, but I'm concerned. Something's definitely not right. So I think that's just a story for our providers to go, listen, safety looked good. You're moving them. Everybody's happy, but you got to be willing to back out of it and go, no, because I've heard stories of where therapists didn't recognize that and it didn't turn out well. Not in the military. It's a civilian setting, but I think that would be an example of a lot of collaboration with your teammates, with your primary care physicians, or your specialty physicians, because that's the luxury we do have in the military. We're able to communicate. So safety is number one.
Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.